apologies for the change in kickoff. We did aim for a couple of weeks ago, but a couple of personal things came up, so we had to change the dates. So welcome to everyone here tonight. Well, I guess we better introduce ourselves. We were pretty bad at that in the previous webinars. My name is Forsayeth. I'm one of the two owners of Advanced Animal Dentistry. I love veterinary dentistry. I have membership in veterinary dentistry and have worked solely in referral practice with dentistry for the last 16, now going on 17 years. And my business partner is Dr. Beck Tucker, who's my wonderful co-host tonight. Do you want to say anything, Beck?
Well, I don't know. I'm probably popping in and out, hey, so I'm keeping quiet.
Yeah, apologies for that tonight, guys, as well. We failed to check on this earlier today, but Zoom has changed in the last couple of months, just a little bit. So there's a couple of buttons that aren't there and some new ones that are. So hopefully it comes off without a hitch tonight. Just a quick reminder, on your screens, I hope somewhere, is a Q&A panel. We encourage you to use that throughout tonight's webinar and certainly future webinars. It helps us, I guess, get a bit of feedback during the discussions, and we can hopefully see your questions pop up and answer them for you. And just that system versus the chat is just a little easier for us to keep track of. Okay, so maxillary canine extraction. Both of us know that this is a potentially problematic extraction that we all face. Some of us on a daily basis, sometimes not so frequently as that. But even sometimes once you've got on top of things, it can even be difficult, even with experience. So what we wanted to do is discuss, I guess, our approaches to the maxillary canine extraction in both dog and cat tonight. Go through the process that we use, I guess, step by step. Cover off on some tips and tricks that we think might be useful for you. And I guess also address complications as well, because unfortunately, things don't always go to plan. Things can be or go awry, I suppose, during that. Okay, so I guess we're going to show a few pictures tonight and videos as well. The videos we do, the videos are of a couple of different patients. One, I guess, unfortunately, I still always call them patients. One is a cadaver. He was ethically sourced, so there's no real concerns there. And the kitty cat was a patient that went home at the end of the day, and we certainly have gotten permission from the owner to be able to utilise these images and videos of the kitty. In regards to the video tonight, we have watched this ourselves while we've been displaying it over Zoom. We do appreciate it's a little choppy, so apologies for that. It looks a little bit animated. It still gets the points across that we want to address. So hopefully it will, in conjunction with us, will speak for itself. Okay, so tonight, what are we going to cover off on? I guess I already have said that. We want to discuss the what we might need to get you to go Bing. I go Bing. Hey, thanks. So you can change slides.
Yes, I'm still struggling trying to figure out this.
So yeah, as I said, tonight we want to cover off on our general technique and approach to these teeth and how we surgically extract them, go through the tips and tricks and complications. I guess for surgery we believe is the best approach to maxillary canines. The way I tend to view it, it's much like many things in the world. Everything's on a big scale. We have a group down one end and a group in the other, and to be honest, most of things end up in the middle. I guess this bell curve of data, and much the same for maxillary canines. You certainly will come across canines that go, I can get this guy out with my fingers. Like, it's pretty straightforward. Why would I need to do surgery? There's not much to it. And then on the other end of things, there's no way in the world that there are maxillary canines, say for a recently fractured tooth, a complicated fractured tooth that has pulp exposure. There's no way that you're going to take that out without surgery at all. Again, there's a lot of teeth in the middle. I guess going back to that tooth that you might think, oh, well, that comes out with my fingers. My concern is with all of those, more so in dogs than in cats. Have you ever come across many oronosal fissures in cats, Beck? I can't remember. Yeah, they're very rare.
They've been really, really chronic sort of fractured teeth in pretty old cats generally.
Yeah, absolutely. It is rare in cats. But certainly in a dog, if you've got advanced periodontal disease or advanced endodontic disease that has destroyed a lot of tissue around the maxillary canine, you may well have an oronosal fistula present. And so, sure, you don't need surgery to remove the tooth, but you'll need surgery to close the oronosal fistula. And luckily, it's the same surgery, so that's pretty cool. So we'll flick forward now onto the 4 parts of a surgical approach to, and this goes for any tooth, I guess. The basic parts, I'll ding on to the next slide back. The 4 parts to any surgery. We need to access the bone, because ultimately with a surgical extraction, what we're trying to do is change the bone around these tooth roots. If we can do that, then the aim is that will make our extraction easier. So we need to create access to the bone by creating a mucoperiosteal flap. Then we do remove that bone, and we do that with our high-speed burr. Usually we don't do it any other way. Sometimes I have in larger exotic patients, I use something as gross as a hammer and chisel when we're dealing with very large teeth. But no, high-speed burr is what we generally use. Then we extract the tooth. 2 simple words there: extract tooth. Straightforward as that. With good preparation, it should be as straightforward as that. And once that's all done, we've accomplished removal of the tooth. So we then need to close that mucoperiosteal flap. So they're the 4 general steps that we follow to perform any surgical extraction of a tooth. But first up, we're going to run through some videos of the extraction of a maxillary canine tooth in a dog. I think the next slide just says
pretty much
maxillary canine extraction in the dog, just to remind me what I'm doing. And so first slide up, we're going to have a look at this dog here. We'll get that next slide up.
Well, we've got to go through what we use first.
Oh, well, yeah, sorry. I'm keen to get in there and get this tooth out. Exactly, Beck. So you do have to be prepared for it with instrumentation. It's not hard. We've generally got these things lying around anyway. On that point, no, I wouldn't have them just lying around. I wouldn't use them necessarily straight out of a general surgical kit. What we are working in pretty small area, and we've over the years and certainly into the future we'll continue to do so. We put together our surgical kits that are aimed at these smaller surgical areas. So we use pretty fine instruments, as you can see, but they're not complex. We have scalpel handle, gone are the days where we wrap it back in the foil that it came from. We have sharp scissors. These iris scissors that Beck has here, they're really lovely, nice and sharp. Don't let me at them and let me cut your sutures with them. We do have
not iris, they're Lagrange scissors.
Oh, sorry. you intervene. You tell me the fancy names for it. They're my snippy snip things. We do have scissors specifically there for suture cutting, and you do want those to be quite sharp and precise, because with what we're doing in the mouth, it goes together well, but putting poor tension or bad tension on our surgical sites can tear our sutures out. So you don't want to have a half cut through suture that you pull on and it tears out. So nice sharp scissors is important. Small needle drivers and small forceps.
Yeah, I think those needle drivers are 14 centimeters. And those forceps are a Bishop Harmon, but there's two sizes in those. We've got both. The smaller ones are too small. This is the larger of the two.
Yeah.
And they're just a 1-2 rat's tooth.
Yeah, absolutely. That would be, that's my preferred pattern of the teeth on my forceps. I guess we can see here, we do have a pack of 4O here, which we generally all know the sort of size of. So yeah, the instrumentation is quite small. And on the left, general extraction instruments, some elevators there, some flips, but also on the right of that, that's a Molt number 9 periosteal elevator. That would be the size periosteal elevator I would use in the majority of medium dogs and up. And we'll see that in use quite soon, actually. And it's quite an important piece of equipment. Can you do it without it? You can't do a good job without it.
No.
Yeah.
Or some form of periosteal elevator at least.
Yeah, exactly. Yeah, exactly. It doesn't have to be a Molt number 9, but I think they're quite well suited to what we're about to do. So I guess let's get started with that. Next slide.
This one's just an extra addition, actually, because we've been struggling to get monocryl, which is probably the preferred suture over monosin. So it's a polyglocaparone 25. It just has slightly nicer handling properties, similar absorption profile. We've just tried some of this and we're pretty happy with it. So it's an alternative brand. I guess the monocryl, I think on the reverse cutting needles, we've been advised is no longer available in a dyed suture, just a clear, which I struggle with quite a lot and prefer to dyed. And there's word coming through that we're going to struggle to get the monosin as well. So we've tried this. I was actually really happy with the needles. It stayed sharp. Probably more so than the monosin. It was actually a little bit nicer. Knot security was good. So all in all, we're pretty happy with this. So that's just an alternative if you are struggling to get your old trusty favorites that we've had, a positive experience with so far. So
yeah, no, I agree. It certainly feels nice. The feel of it is good. So yeah. We were looking at getting a few boxes in actually very soon.
Yeah, give it a go. And price point was pretty good too. So
yeah, it was good indeed.
Yes.
Okay, so
I put a little drawing on here first.
Yep.
So basically, we'll just use this. I'll draw on this picture just to show you, I guess, our flap design. There's a lot of different sort of ways you can do your cuts to create a mucoperiosteal flap. Will adapt to the individual situation. And a lot of it will depend on size of the patient, I guess what you're trying to achieve, the degree of disease of the tissue. If you've got an oronasal fistula present, you may change things. If you're taking out an entire quadrant of teeth, then you may also sort of adapt your flap design. So if we're just dealing with the canine teeth, not really taking out any other teeth, my favorite, and Aaron's as well at the moment, our favorite sort of flap design is to do, and now it is not working.
It's going a bit wonky.
Ugh. Here we go. Need to pick it up. So basically, we'll do a nice diverging sort of vertical release incision at the rostral margin of the flap. So you don't want to be going straight up and down here. You want to make sure that the base of your flap is always wider than the tip of the flap. I'll then sort of cut along the actual gingival margin, and now sort of I'll bring my flap pretty much back level with the first premolar tooth. And for both of us, that will generally give us plenty of access. We can sort of reflect it to triangular sort of shaped flap, and that works works really, really nicely for us. If I need a little bit of additional exposure, I might just make a little nick up here, and that will give me a fair bit of extra sort of exposure and access to that distal component of the actual root. You can, if you need to, extend it back over the first premolar tooth. It's ideal not to, because if you do that, you will get reattachment of your gingiva, but it will ultimately result in a little bit of remodeling of the bone. So it's something that in an ideal world you'd want to avoid. There are also adaptations of that flap where basically you do your vertical release along here, and then you come up along and above the actual gingival margin to preserve that. So if you need a lot of exposure, that's another way to get that. So that would be our preferred sort of method of, I guess, creating a mucoperiosteal flap. Previously, and what many of you may do, is to make an incision here and an incision straight up here. What we find with that is you'll often end up with a flap that's almost as I guess wide as it is long, and that goes against a lot of the principles in flap design. Also, by making a very vertical release distally, you are potentially compromising the blood supply a little bit more to the flap. That said, I mean, we did that sort of flap design for years with pretty minimal problems. The blood supply in the mouth is very, very good. So I don't think you'll have too many issues with it. But I guess in our hands these days, we find that that other flap design works really well. It gives you excellent exposure still. And it's something that you can go minimal. And if you need more, you can always increase your exposure as well. You can also extend this incision a little bit further vertically if you need to, just to reflect the tissue back a little bit further. So that's our current recommended technique for that.
Yeah, the old technique certainly held me in good stead for 20 odd years. Yeah, and it's not terrible, but I think certainly, but yeah, both of us are sort of, not exclusively, certainly as we've worked together for a number of years now, but I think we've both come to the same kind of decision through multiple cases that this is the flap design that works best for us currently.
Yeah, it does, and we get pretty minimal breakdown. If you do end up with a bit of breakdown as well, I think you get less retraction of the tissue. If you do, you might just end up with a little bit of opening at that mesial or rostral portion of your flap rather than the whole thing retracting back up. If you've got both, two vertical releases, and if again you have a bit of breakdown, things just seem to be less significant for the patient in terms of the impact of that. So
yeah, for sure. Okay, well, let's watch the video, and in this first little bit of video, Beck's going to approach this dog and do what we just said. Hold
on, managed to zoom in now.
That might be a still image. I was actually going to use that for you to draw on. The other one previous might have been the video.
Really has had a little meltdown.
No, it's not happy, is it? There we go. So again, apologies we do appreciate it's a little bit stilted. But yeah, here we go. Come on, video. So here's that distal incision between premolar 1 and the canine there.
Yeah.
And the vertical mesial incision. For some animals, all animals, be careful of it, but certainly in our smaller patients, not so much the brachycephalics, but certainly they are in that group as well. Just watch the dorsal point of that incision there. That can actually plunge into the nostril, and then actually into the nasal cavity. You'll go over the edge of the nostril there. It's unusual to do that, but it is there. That's one thing to be on the lookout for.
There is a nice little blood vessel up there too. I just paused it here. I guess if you'll probably notice that after I made my incision at the corner of the flap, I inserted my blade and just rolled it. I find that's a really, really good way of actually lifting the corner of your flaps. One of the hardest things to sort of get going and get started. So sort of cut away from the actual flap towards the outside of the tissue. And you just basically, you insert the blade in and just roll it, and that will just help lift that little corner for you. That works a treat for me.
Tip number one. Yeah, no, that is a good one. Because when we get to it, or when Beck gets to it in a second, lifting that mucoperiosteal flap, getting it started is your hard bit. Getting that gingival lift off the bone. It is very tightly adhered. It should be very tightly adhered.
Yeah.
So Beck's also showing there another direction you can go, and where the root is headed as well. For all of these, you should have a good idea of course, your anatomy. Now that may have come through from at the time, or at least recent radiographs. It can come through, I guess, general knowledge. You can also feel and sometimes sort of see where the root's headed as well with these guys. So you need to make, not usually a great deal of, but you do need to make some kind of adaptation of your flap for the anatomy of the tooth that you're removing.
Absolutely. I guess just with the elevation, if you are using a Molt 9, you always use the pointy end of the actual periosteal elevator to, I guess, start that initial part of raising the flap. You want to make sure that it's held relatively flat against the bone, and you want to almost dig the point in a little bit. You don't want the point sort of, I guess, pointing up at all into the soft tissue. That's when you're really liable to actually, I guess, tear your flap. So you sort of want to keep it fairly flat and adapted to that bone and tooth surface, with the point making sure it's sort of, I guess, directed slightly towards the bone, not the soft tissue.
Yeah.
And then starting on a corner really does help. So you can see how relatively easy it was to lift that corner up, given we've sort of just given it that little bit of a start with the blade. Once you get under there, I continue to use the pointier end, and I'll use it in a swiping back and forward sort of motion. And that is really useful to lift that initial portion of attached gingiva. So be really careful at this point that you don't sort of, again, pierce the soft tissue. Once they get to that point, I'll flip to the flatter side and basically just use that in a pushing sort of motion to push the rest of the flap up. And once you've got the attached gingiva raised, the actual alveolar mucosa should be relatively easy to lift. So for me, that's probably enough exposure. But if you need a little bit more at this stage, that's when I'll make that little extra incision vertically. And I don't make it as long as the rostral or mesial incision. It's really just the level of the attached gingiva to the mucogingival line, and that gives plenty for us. Again, if you need to do more, you can extend it back over the first and second premolar at that mucogingival line if you need to.
You can always do more with these things. And can you go too far? You can go too far, but you've got quite a distance to go before it's too far.
I think that's the other thing I like about this flap is you can start small and increase the size as you need to.
Yeah.
Whereas with the ones where we were doing the sort of rostral and distal vertical releasing incisions, it was always a biggish flap. Whereas this is nice and wide, which is a really important principle. You want it to be wider than the tooth, so you're suturing over bone. And also, I guess it just gives you excellent coverage of the area once you do close it down. But it's adaptable on the fly. It's sort of, you can start small and keep extending it as you need if you get into a bit of a trouble with the extraction.
And exposure, of course, that's key to basically all surgery, except when we're trying to do space through 5mm holes. Exposure of your site and access to the tissue you're trying to perform surgery on is really important. So I can see here on this dog with that flap the way it is, the area of bone that we're going to be doing surgery with is sitting right in the middle and has a lot of bone on either side. And as Beck said, this will mean that unless we go crazy with our burring away of bone, we will close that flap back down and have the suture lines on top of bone, which is always a happier place for them to be. Okay, so yeah, so this guy, we've got the flap up and we are about to start performing bone surgery. I call them bone incisions. I think it is surgery. So I call them incisions as much as we're about to do it with a high-speed burr. So the general principle is we want to remove the attachment of a piece of bone from the skull. So that piece of bone that we're removing the attachment of is this buccal alveolar plate. It will be through our cuts, it will be dissociated from the maxilla.
Yeah.
And the other thing that we're going to do as well, so that will be a 3-sided cut. Yeah, there's going to be a mesial cut. Beck looks like she's about to draw it up there. There's going to be a mesial cut, and then there's going to be a distal cut, and we will join those two as well. Now, it's not that much of a tip, it's actually a warning. When you do that third cut to join the two, don't cut too deep, or else you'll cut a big trench in the tooth that makes it weak and it may snap at that point.
Or alternatively, if you're not quite sure of your anatomy, and it's something I did for a very long time, what you can do is really try and follow really closely to the actual tooth surface, but you can take off really, again, being very shallow, you can actually color in and remove that really superficial alveolar bone with your burr, and that will expose the underlying tooth surface, make the anatomy much more clear to you. So if you're not certain about where to make these deep sort of trenches at the front and the back of the tooth, exposing the actual lateral tooth surface first can just make that a little bit clearer for you.
Absolutely.
So again, with time and practice, you just find that you're confident enough that, and you get a patient where you can actually really see the anatomy well, like you can with this one. I think it's pretty clear that you've got basically the tooth running here and it runs up sort of to there. So I'd be pretty confident in making a nice, narrow but deep cut at the front, narrow and deep cut at the back, and then a really superficial sort of cut across here that basically joins up to the sort of mesial and the distal cuts. And that effectively has removed that bony surface. But again, if you're not confident, just color in, remove it, and expose that to sort of tooth surface so you know exactly where you are, and you can sort of orientate yourself and then make those deep cuts front and back.
Yeah. And look, asterisks to all this, we appreciate this. This is, of course, the cadaver that, again, ethically sourced. So no bleeding here. And then we appreciate that makes it quite a straightforward thing. It's very easy to see, which makes for a good demonstration, but we do appreciate it's a little bit different from reality. So yeah, so we do those 3 cuts, and certainly the mesial and the distal cuts also perform another function. So it is removing the attachment of this buccal bone plate, labial bone plate from the skull, but also we're creating, they actually are deep. And after the video, there's a quick diagram I did up this afternoon that I hope shows what we mean, but it's the incisions are made to the depth of the thickness of the tooth, if you get what I mean. They're going to go down to the other side, to the nasal side of that tooth. Not into the nose, hopefully.
Almost start to wrap around that palatal surface. So it allows you to wedge your elevator in and sort of hook it around the back of the tooth to sort of lift it up towards you.
Absolutely. So we're dissociating the bone, removing the bony attachment, but what we're also doing is providing a space for our instrumentation to enter, because of course you've all performed extractions, and sometimes the hardest part of an extraction is actually getting your instrument between the tooth and the alveolar wall. Here we go, high-speed burr.
Yeah, The 1558 burr, which you may not have heard of. We love them because they
go
can
through life.
function in, I guess, in essence, as a round or a taper fisher burr. They actually have a rounded end on them, so you can actually cut with the end. And I really, really like it. So it'll stop us when we're lazy from having to swap between sort of a round burr or a straight. If I was using a round burr for this, I'd use a number 4. If I was, and I would use that more to remove the buckle bone. To make these deep cuts, I'd probably use a 701L if I was using one of our more standard burrs.
Yep. So those 2 incisions have been made. I think we are going to go, or Beck's going to go back and make them a little deeper. But they've just been joined with that through that shallow cut just through the bone.
Yeah.
I'm trying not to put too much or damage too much the tooth root itself. But here we're going. And again, if it's stuttery for me, it's probably stuttery for you guys. Where I'm seeing this deeper cut, deeper channel. We were discussing, what do you call these things? We call them moats. That's sort of our best description.
Yeah.
So there are these incisions mesially and distally to the tooth root. We're not cutting through the tooth itself, although if you're going to err on the side of cutting through some tissue, you can cut through a very small portion of the tooth root. And they've been created and made a bit more deeper.
Yeah,
a bit more deeper.
Right. Yeah. The other thing, I guess, to take note of is the way we actually hold the high speed. If I can go back a little bit, you notice that I use a finger stop. So I'll always be stabilizing my hand with a finger resting against tissue, hooked around a tooth or the likes of that. We hold the high speed in a modified pen grip fairly close up to the head of it.
Yeah.
And I also don't just sort of, pop the drill in and try and sort of pull down and cut. It's little sweeping motions. And that sort of, I guess, clears the burr of debris. You'll find it'll bind less. And it's just really sort of gentle, controlled sort of motion that we use.
That's actually really important to say, Beck. So developing skills in handling a high speed do take time. You don't know how to use it straight away. It takes a lot of practice. Practice on etching your name on your stethoscopes.
And ruin your high speed.
I won't ruin it. Just have to write another one. But yeah, so probably 60% of the time is spent not cutting anything. You cut out, cut out, cut out, cut out.
Yeah.
So here Beck is going over the buccal surface here and actually doing that colouring in and removing a lot of bone. So now we can see there's quite a lot of root exposed, and I've decided to zoom in when I was filming. And what we should know from our previous knowledge about anatomy, the bulk of the holding power of any root is in this top 30% the coronal 30% of the alveolus. So with this having been done, we now have no attachment on this buccal surface. With the deep trenches on either side, we have no mesial attachment. We have no distal attachment. In this coronal 30%, and this is getting probably close to 40% actually of the root length, we only have palatal attachment. So we've reduced this by a significant amount already. And as we can see, we now have an instrument placed in this moat on the mesial aspect. Hopefully, fingers crossed here, we'll be able to apply enough force in here and that this tooth should be removed in quite short succession.
Fingers crossed. The other thing, I guess, is just take note of how that instrument's being introduced into that cut. Obviously, the cut itself isn't too wide, so the instrument's really well seated and it's tight. If you make your cut too wide, your instrument's going to flop around in there, and when you insert and rotate, you're not going to get much purchase. So that's the real trick to these moats that we create.
Absolutely.
The other thing to sort of really take notice of is the direction that we're holding the actual elevator or luxator in this case. You really need to keep the long axis of the instrument in line with the long axis of the tooth. If you come in and you've got sort of, it doesn't like me putting hands in. You've got your tooth here and your elevator's sitting like this and you're trying to wiggle, you're not going to do much. If you come in and you're basically following that long axis and you rotate, you're going to transfer all that force to the actual tooth and down the length of the root. And that's the key to it. Always keep in mind the anatomy, the way the actual tooth or the root is running in the actual bone, and keep your instrument basically in line with the long axis of that tooth root, and you'll probably find that you're much more effective and efficient in your luxation and your elevation. You can also see that that cuts deep enough that we've chosen the right size instrument. You want the instrument, the curve of the instrument, to basically adapt really well around the curve of the tooth. If it's too big, it's not going to do much, and if it's too small, you're really just going to be wedging it in there. So that's another sort of thing. Make sure you've got an array of different sizes. That said, we probably stick to a 2 or 3 millimeter and probably have a 5 or 6 millimeter for the biggest teeth. And that will do most, but we still have all the others there. Just for those odd ones, we need something additional for.
And another thing that I'm seeing here as well, Beck, you've got your fingers nicely placed right close to the end of the working point of an elevator. So if you slip, you're hopefully not going to go too far into the animal.
Yeah, no eyes, no noses. And also, I guess it's a modified tennis grip, that. So you've always got your finger basically extended down the shank of the instrument. And again, right there, I'm using it as a bit of a finger stop as well, to help stabilize my hand as I actually rotate. And I guess, as we've all been taught, and probably don't do very well, the key to sort of your elevation and luxation is, once you've inserted the actual instrument, you rotate and you hold for 10 to 15 seconds. The thing that I guess we notice when we're teaching the students out at uni is they'll do that and then they'll pull out as well. So insert, rotate, hold, go back to a neutral position, and then push in a little bit further, and then do that again, and do that a couple of times before you switch positions, and that will get you deeper down or into the alveolus as well.
Every time that you want to place force on these teeth, it needs to be different. If you keep doing the same thing, you will get the same result, which is no movement and no breakdown of tissue.
And
so
a very,
it does need to be different.
Frustrated bit.
Yeah, it needs to be different to some extent. And I guess, again, going back to workshops and working with students who are doing this for the very first time, it is, as Beck said, it's actually a pretty natural thing to do. You put some force on, then you pull it all out, and then you start again. But often they go back to the same thing. They get nowhere. So we'll keep pushing on with this dog, and again, fingers crossed, Beck can place enough force on this to break down the periodontal ligament. I'm just going to rotate here. Yeah, and as Beck's already mentioned, so that's a really nicely matched elevator to that tooth. That inside curve there actually fits that curve of that root quite well. It cups it, and that is a nice even distribution of force. You'll have more problems with fracturing tooth roots if we're putting quite a lot of force on a single point. But the more we can have an elevator fit the tooth, the better distributed the force will be. Okay, so we've opened the flap. We've gotten.
I think I fixed it.
Oh, wow.
Huh?
Very good. we've elevated the flap. We've gotten access to the bone. We've performed some bone surgery, and now we are elevating the tooth. And I think in the next clip, we should be able to extract the tooth.
Make sure.
We're very, very close. Here we go. Oops.
Oh,
Actually, here we go. Here's this dodgy diagram I did this afternoon. So this, where are we looking? We're sort of looking, we can be looking VD or DV on it. The top part of the screen is the buccal surface of the tooth. And the blue line, I guess, represents the nasal surface. But we can see now in cross-section those deep moats or trenches on the mesial and distal aspect of that tooth. They go to sort of the depth of the tooth. They come close to the nasal bone.
So you're sort of putting your burr in.
Yeah, correct. Yeah. So yeah, don't just make a little line. Cutting there, as we said, it provides a space for your instrumentation. But also, if you think about it, now we've also dissociated the bone from the tooth on both the mesial and distal aspect. Now there's no attachment. The only attachment now is on that nasal surface. Okay, so next slide, we'll extract this tooth, I'm pretty sure.
I think we've already gone over that. That was, I think, more to demonstrate exactly how to insert the instrument, and I guess what a decent fit that is. Also, I guess the finger as well, you can see on the other side of the dog's head, that's my I guess other hand that's used to sort of support the nose, to stop the sort of head moving. So I always sort of have one hand over the top and then my other sort of hand coming in with the elevator.
So if we all hold hands and pray, we'll get this tooth out. And we do that wiggle. That's certainly what we do something like. We want to see how much movement we've got before we start applying forceps pressure. Little peek behind the curtain. That tooth came out really quickly. We had to put it back in to show you that it actually elevated straight out rather than having to be removed with forceps. In saying that, yes, that was a bit of a giggle, but for a lot of these teeth, you will be able to elevate them out. You shouldn't be using a hell of a lot of force to extract them with forceps. With this appropriate preparation, appropriate removal of bone, and good elevation, these teeth will come out without yanking on them or having to bulldoze them out or pop a shoulder or anything like that. With the finesse and technique, they will come out hopefully pretty easily. Yeah,
they generally do. And if they don't, like when you just take off more bone, like you will come across those that are ankylosed, especially old cats.
Yep.
And if you've sort of done all of that and you're not quite there, I don't actually spend with upper canines a huge amount of time elevating if I am not getting some movement relatively quickly, because they really do have sweet spots, these teeth. If you've made your moats and your cuts appropriately and you're getting around sort of the front and back of this tooth and sort of getting your elevator in just around that palatal surface, and if you're not making reasonably steady progress and getting movement fairly quickly, I'll take off more bone. And at the end of the day, you can take off a fair bit of bone in these guys. You always want to be as conservative as possible, so don't just expose the entire root straight up. But if you're not making progress, don't keep persisting for half an hour or something. Take off a little bit more bone, relieve a little bit more attachment, and then start again.
Yeah, absolutely. Okay, so now we've accomplished what we wanted to. We've got the diseased tooth out.
There's a question as well.
Yes.
Yeah, so the question is, if it's ankylosed, can you leave some root, especially in cats? I guess probably important to define the difference between ankylosis and tooth resorption. I guess if it's just just ankylosed, it can be really hard to get out, but you should be able to remove it, especially an upper canine tooth. I guess the maxillary bone's not as dense as the mandibular bone, and you almost in some ways feel like you're peeling the tooth out, and it'll come off with sort of this fluffy sort of spiky appearance, but you should be able to get it out. And I guess in our hands, we'll probably, even with fairly advanced tooth resorption in maxillary canine teeth specifically, mandibular is a totally different story. We'll even sort of always attempt to take the whole tooth out, and you'd be pretty shocked about how much tooth actually comes out. Some of them look like absolute ghost roots with very, very similar density to the surrounding bone, and you'll still almost always get an intact root out. So always attempt it. If it's truly ankylosed or resorbing and you leave some behind and you don't have endodontic disease, so you don't have a fractured tooth with a tooth root abscess, and you're, removing it above the level of any periodontal disease, then it's unlikely to cause a problem. But I guess it's always, for us, we'll always attempt to remove it. And in a maxillary canine, it's pretty rare that we'd leave anything behind. And in fact, I'm bit too stubborn about it, I think, and we'll always spend far too much time trying to get even the tiniest little tip or shell of the apex out. But yeah, I'd say always attempt it. I guess if there is really advanced tooth resorption, there's nothing wrong with doing a crown amputation, except I've been burnt because always the ones that break down are the ones you've crown amped, and then they take forever to heal or don't heal well because you do have tooth material that's exposed and the tissue really struggles to migrate over that.
Yeah, I think you're right though, Beck, what you said initially. It is important to separate whether it's pure ankylosis, which we can see across the board with any tooth without any other pathology, and ankylosis that's associated with type 2 tooth resorption. Ankylosis itself is this situation where the surrounding alveolar bone binds to the cementum. That is ankylosis. It does occur in type 2 tooth root lesions, and type 2 tooth root lesions are where we have resorption occurring within the root and there's invasion of bone within it. So technically they're very similar, but we do treat them differently. If it's pure ankylosis, we would generally go for a full removal, which means carving the tooth out if we need to, actually physically cutting the tooth out the entire way. But yeah, if it, as Beck has explained, if it actually has type 2 resorption, then we can look at, and I do the same, I would always attempt a full extraction if possible. To be honest, I am a little lazier, and because I know that I have a backup of crown amputation, so if it happens to fracture, no sweat, we just actually then clean it up as a proper crown amputation and close it all over.
Yeah.
So, and this is about what we're about to do with this dog here. We're about to clean this alveolus up now. So it has had its, again, we've achieved what we wanted. We wanted the tooth out. It's out. So in our broad range of disease states here, we may have, again, endodontic disease, which may have maybe a root tip abscess. So we'd like to get into there and clean that out of the granulation tissue that's in there. If we have significant
oronasal fistula and it's full of delicious cheesy purulent material.
Yeah, that's right. If you've got advanced perio, we may have no bone on that palatal surface as well. So the next video is going to show that. We're just going to quickly, again, Beck's going to quickly go over this alveolus with a. She does use
already done that one, haven't we?
Yeah.
Yeah.
You're just showing off now.
No, that was a freaky tooth.
Yeah. So we're getting here periosteal elevator. And we're going to...
or a spoon curette.
Spoon curette, yeah.
This one's an old periosteal elevator I don't really like. So it's become basically the tool that's we use to curette the sockets. The other thing, I guess, and it's not really relevant in this particular individual, is often when you have advanced periodontal disease or you've got an oronasal fistula, for example, you'll have invasion of like granulation tissue or epithelium up I guess, the palatal side of the tooth, so on this bony surface. You always want to make sure you debride that really well. It's imperative, if you have an oronasal fistula, that you clean that up and you get a really nice fresh tissue margin with no invasion of that tissue into bone, or you're almost guaranteed to have a breakdown. So really make sure you curate any debris out of the actual alveolus, but also that you really, really, really need to just debride and clean up that palatal mucosal surface if there is sort of, I guess, damage to it or invasion of tissue up that palatable aspect of the tooth.
Yep. If you're running into a situation where you do have an oronasal fistula here, you do want to clean out, I guess, all the goobers. It's going, again, it'll be bleeding a lot. And you're going to get blood coming out of the nostril there. What we're doing here is we're just cleaning up the bone edges. So Beck's got a round diamond burr here, leaves a really lovely smooth finish, and just running around those incisions in the bone, smoothing them off. We would prefer not to have our mucoperiosteal flap close over sharp edges. I think that's quite important there in those corners.
And a diamond burr's nice because it's far less aggressive. Like, I'll often use one of our cross-cut Fisher burrs or what have you, again, because I'm a bit lazy, but you'll often gouge the bone and then you have to sort of clean it up and take a little bit more away. You won't do that with a diamond. You really will just smooth it away, and it's very hard to take, I guess, too much off. Yeah,
no, it leaves a lovely smooth surface.
Okay,
okay, so that's a prepared site now. Again, we didn't have access to a really nasty one. Click on to the next one. We've done that one. Yeah, so what are we going to do now? Well, there's still a couple of steps before we close it all up. What we're going to do here in this site, we're going to lift up these the gingiva and the mucosa on the edges. Why do we do that? We want access for when we suture. We want to be able to get a needle tip under that edge, and it goes here for the palate as well. As you can see, we need to have a mildly free palatal edge. It doesn't need to go extend millimeters into the anywhere. Just have to have 1 or 2 millimeters free that you can get a needle in and under.
And it just saves you're less likely to actually tear the tissue, especially in a cat at that mesial border. It's really tightly adhered, and you'll often try and get your needle around, and that's when you'll tear. So if you've just lifted that attached edge a little bit, it makes it much, much more straightforward to get your needle in and to suture a little bit less traumatically.
Yeah, absolutely.
Is that the next one? Yes.
Okay, so this will come up in tips and tricks. It's not even a tip. This is key to closure of successful closure of mucoperiosteal flap. It's mucosal plus in brackets gingiva and periosteum. Periosteum is inelastic. We have purposefully lifted it up. We want that tissue, but it's inelastic. So if we go to close this flap, I'll also make some excuses here for this video. This is tricky, and you need to be quite specific with what you're doing. I couldn't shift the camera in front of Beck's face.
I wouldn't get out of your way.
Yeah. So I appreciate that there's a bit that you can't always see.
You really do need good lighting and to sort of be able to sort of, get under and look what you're doing.
Actually, that's the shot you want. If you actually go back a bit back, that's the shot you want. Now, again, in a live patient, you don't get to really see this. You will in some cases, certainly in the bigger dogs, you'll see it. But here we can see on the inside of our mucoperiosteal flap, we have that white sheen is the periosteum. Yep, and Beck's outlining it now. And the two blue lines used to be together. But now they've been split by careful incision, and the mucosa is elastic. So now this allows this flap to close down without tension. You hear us all bang on about this no tension, but the reason we do is because it's vital. If you even just holding the edge to edge and you think, oh, well, I'm not pulling it too tight, that's still too much tension. And what I think in the next video, what we show is that we can put it there and leave it and it doesn't move.
Yeah.
That is what we mean when we say no tension. Now, the technique here to cut this is scary as hell when you're in a cat, because we all know those flaps are like 0.1 of a millimeter thick anyway. So what I often, and still to this day, I still do, and I do encourage people to do it at least when they're starting, use the back of the tip of your scalpel.
Yeah.
So sort of to scratch, and you will feel the fibers, you'll feel it as it breaks down. As you have done a few more and you get a little bolder, and certainly if you're working with a bigger animal, you will use the open face of your blade to incise that periostea.
You can also, I guess, what I'll often do is you can see I'm holding the flap with my fingers there. If it's big enough and you can, it actually gives you a bit more tactile feedback, because if you put sort of one finger down on the back or the mucosal surface and you're holding it between sort of thumb and forefinger, you can actually feel the fibrous bands of tissue. So if you've released it and it's just not coming that bit further, if you rub your finger along the actual buccal surface, you'll actually feel the bands of tissue still. And if you're feeling that band of tissue, that's where you pop your blade and just sort of tease those fibers apart. You can also use those Lagrange scissors that we spoke about before. They're beautiful, and I would probably use them on, all dogs now. I don't use them on cats because they're scary. But essentially, what you can do is just at the corner of the flap, introduce the tips of those scissors, just gently sort of open them, and you can see it here where I haven't completely sort of resected through this tissue. You insert the tip of your scissors here and gently sort of slide it in and along. You can just open the blades and spread that tissue. I always look at sort of on the back of my flap to make sure that it's not penetrating through, and then you can cut, and that gives you a really clean sort of cut. And you can sort of, I guess, continue to do that more and more to get more release. So if we've got an oronasal fistula with a lot of tissue retraction and recession, we'll basically just sort of dissect up a little bit higher and continue to sort of tease those fibers apart until we get tissue sort of releasing enough to allow that flap to come down and sit over our fistula site.
Yeah, excellent. So hopefully we have achieved that. And again, that it really is an important step in the closure, and a successful closure here. So we'll zip on to the next bit of footage. So we'll just finish that. Everyone's happy. Okay, and that right there, that flap has been popped there, and it's not just because it's a still photograph, it is sitting there by itself. No tension whatsoever. And that flap looks great and ready to go for suturing. Yeah, just drop it there. There it goes. Nothing. Perfect. Okay, so suturing. People do use, I guess, a couple of different techniques. Generally, simple interrupted. We've never particularly strayed from that too much. I've experimented with continuous. I don't really like it in this situation.
Done inverse sutures as well, but
yeah, exactly.
I find them time consuming. The knots still want to poke out sometimes. So
yeah. So this is that 4.0, or this is actually just 4.0 monosin right at the moment. And Beck and I both do similar. We both place our corners first. So just general placement of the flap where we want it to sit. We pop a corner in. Again, nice sharp scissors here. And they're going to come in, and just using the tip, we don't have to get it seated way back. Boom, gone. No mucking around, not using two arms to close it on there. It's snipped. We can move on. If you have a nurse with you, it is lovely to have them retracting lips. It is great to have them be cutting your sutures for you as well. I leave about 2 to 3 millimeter tags on them. You don't want to get too close, they'll open up. You don't want to leave them too long, they get a bit itchy.
That one didn't want to go through. The other important thing is, I guess, suture from the flap side first. You want to go from the flap and then into your attached tissue. And yeah, don't sort of try and go through both in one hit.
Do 2 passes.
Yeah.
Like if anyone's ever worked with us and seen us what we do get lazy, and I will try and do a pass and think, oh, I've saved so much time. When it works, it's great, but when it's not, you're putting some really bad forces on your flap, and you again are potentially going to tear it. And they're pretty tough, but they also rip easily. So you do have to be careful,
especially in cats.
Yeah, absolutely. Okay, so we've got the two main sutures there opposing that flap. We're not going to bore everyone with all the sutures being placed, but look at this. This is a really good example of a flap that's sitting nicely back in anatomical position. Yeah, those sutures are great. I don't think that's going to cause that dog any problems.
And this is the other thing I really like, I guess, about that flap design, is that there's no, I guess, pointy corners to it. It ends up having a really lovely curvature to it. And I think that is something that helps quite a bit with healing as well.
Absolutely. Okay, so that's cool. So this dog is done. Generally what we would do, we send our guys home. Pain control is important. Antibiotics we just don't use. It's not indicated for this situation. And we'll have them return in 10 to 14 days for recheck. The asterisk on saying that is that we are in a weekly cycle. So we don't often get 7 days is, 10 to 14 days is where we like. I know people are checking dogs out at 3 days. Excellent. Keep doing it. Keep in contact. Communication with your patients and clients is always important. But we generally see ours back at 14 days. If it's all going well, high fives, and yeah, we're done. Then we go at the back and find, oh no, this cat, it has broken both its upper canines. What are we going to do? You want to do a root canal? No, we'd rather not do a root canal. We'd rather get this out. This is an old cat, so we would prefer to have this problem sorted out in one sitting. Which is what we're going to do here. Yeah. So Beck saw this kitty cat recently. Do you know why it fractured its teeth? No one knows.
We think fell off the screen door.
Yeah, okay. Sounds like a cat. Yeah, and so we've got complicated crown fractures here. These teeth are inevitably going to develop periapical abscesses, so they need to be treated, and we have chosen to extract. So Beck, and she'll continue on once I introduce it. She's drawn on here her incisions for her mucoperiosteal flap.
And again, it's really similar to that flap design in a dog. Very much follows the same sort of pattern. And again, if I need to make this bigger, I'll just zip up here, and you can even extend it along there if you need to. I think you tend to just extend it back along that second premolar tooth yourself if you need to. But you'll often find that you get adequate exposure. Like
kitties you don't tend to need to, because I guess the shape of a cat upper canine is quite vertical. It's quite a straight tooth compared to a dog's canine. So we don't have to have generally as wide a flap. Mm-hmm. Now, the still photographs that you're going to see are from one side, and the movie film vision is from the other side. Yep. So
I guess we'll try and whip through this so we don't keep you forever as well.
Yeah. Again, thank you for your attendance. Good to see everyone still paying very high attendance, and
again, that little sort of incision on the corner just to sort of flick the corner up. And you need really quite firm pressure as well. And you'll see I'll use, I'll put my finger right up there as a stopper, just so I'm really controlled with that blade. The last thing you want to do is slip across the palate and cut the palatine artery. Not fun. So again, using a smaller periosteal elevator here. But again, same concept. I'll sort of go in and try and get a corner up first. Got both corners up, and once you do that, again, because your attached gingiva is a lot thinner in a cat, once you've sort of got that and you're over that little alveolar bone bulge, the flap should lift really, really quickly and quite easily. I think the trickiest thing is the corners there.
Corners are certainly the trick here, and with cats, we all come across these older cats, and they've likely suffered from some periodontitis and getting some vertical bone loss. And they also then develop this bulge. that can be quite hard to get up and over. The gingival insertion into the bone is not smooth. It tends to be fingered and pocketed in. So you have to be very careful. You just got to take it easy and take a little bit at a time, lift a little bit at a time, because again, we're dealing with paper here. So tearing it is just frustrating. It can be solved. You can recreate a flap from further up in the lip for sure. But if we can avoid that, that would be better for everyone's blood pressure.
Yep. So again, just a series of stills so you can see. If you need a little bit more exposure here, you can sort of just at that distal margin sort of do a little bit of a vertical incision as well. But I think for most cases, that's pretty decent exposure. If you come across one of those cats that is really ankylosed, or if there is some early resorption going on, and you might need a little bit of more exposure and to take a little bit more bone away as well. So in this one, I'm using similar shape burr. So it's a 1556. So it's just a smaller size, but it also has that round tip on it. And again, I love it. I sort of, if I had to choose one burr for a cat and one burr for a dog, they would be the two, because they're really, really good all-rounders.
Actually, and just on what you just said previous to the burr, Beck, for both dog and cat, it's not imperative, and I guess we've shown that here, but we haven't stated it. It's not imperative to uncover bone all the way to the apex. That's not our aim. And as we talked about, it's the holding power is really in that coronal 30-40%. So that's where we're working. We don't need to expose everything.
The ET tube, we use a rubber band. So we go to Officeworks and get they're quite a large rubber band, so they're not too tight around their head. And we simply just loop it around the ET tube. I really like it because
these are mine.
Yeah.
At the moment, these are my spare ones at home.
They leave a really small imprint in the mouth, and you're not like, if you use a fabric type of tie or the likes of that, I find you're more likely to sort of catch that in your burr. But also these grip the ET tube really well, so the tube isn't sliding around. It really fixes it in position well. So yeah, for us that works really, really nicely.
And for Beck and I, in both of our backgrounds, we've sort of come up using uncuffed tubes in kitty cats. I know people have their preferences. We would, our reasoning behind that, we really want to be careful of the endothelial lining of tracheas in cats. They're particularly more prone than a dog to tearing and damaging. So what the rubber band also allows is just this gentle bit of movement as well. So you don't have real rigid movement of the tube and potential damage.
Yeah.
No, we like them a lot.
That's personal preference. Even in the clinics we work in, there's an array of different opinions on it. For us, that works well, but we'll use really big tubes. We'll use 5.5s and 6s in most of our cats. So it's a very snug fit, and you'll, really not even get any leakage on a leak check as well. So we do go quite large. So we don't have a lot of sort of leaking around the tube itself. And I guess we're working in some tightish spaces in some of the places we work, with a lot of people bustling around. And I've had a couple of times where someone's stethoscope hooked onto the tubing of the circ or whatever and given a good reef. And I think, my God, if I had a cuff tube in, then that cat's trachea was cactus. So again, that's partly our reasoning. No right or wrong there.
And no one's asked the question, but a common question that comes up then, of course, if you're doing dentistry and you have an uncuffed tube, what about all this fluid? I think we've got to be cognizant at all times with all of our patients of where all this fluid is going. And we still continue to work laterally, and we tend to tip heads down as much as we can. So the fluid just runs out the front. It shouldn't pool, and it shouldn't go down trachea.
And we're always just constantly mindful of it, I think.
Yeah, we're really hopefully we are very switched on to that and mindful of what's going on. Personally, for me, and it particularly happens in cats, also can happen in dogs too, I will have to position a head. So if I'm performing a cut somewhere and the head's actually facing me, it's quite vertical, and fluid, of course, follows gravity and goes down. I will. That's the one time I pack a throat. I generally don't pack throats personally. I'm too forgetful, leaving swabs in. But yeah, just be mindful of where fluid goes. It always goes down. So if you make an exit point that's lower than where you're working, it will all go out onto the table or
Yeah, for
onto
sure.
the mat.
So that's just a series of pickies, and I guess again the one on the far right is probably the most useful and important. And again, you can see that moat around the tooth there.
Yeah, so not the whole root's exposed, but the top 30-40% of that is. And now we can fit an instrument in that area.
I think that's a little 3 millimeter, that one.
Yep.
So again, not really quite doing what I want. So in that case, if it's just not, it's sort of, not grabbing, what I'll do is just go back in and deepen those moats around the tooth. So I can deepen those a little bit now. The same video.
Yeah, working from different areas at all times. So again, different forces. You keep doing the same force, you end up with the same result.
Yeah.
So different forces from different directions.
And again, you're sort of pushing forward or back, but also lifting sort of towards you as well. So you want to sort of get the elevator around the back of the tooth and sort of lift it out towards you.
Yeah, you're sort of picking it out.
That's where you haven't released any attachment at all. So
yeah, absolutely. And then nicely, we've got a little bit of movement here, and we're going to rotate, and we rotate these teeth out.
These are much straighter than dogs' teeth as well. So I think putting a little bit of rotational force on them is more appropriate. In a dog, theoretically, at least, you could, if you rotated the wrong way, punch the apex of the tooth into the nasal cavity. I think that's unlikely unless you're close to already having an oronasal fistula. But in cats, they're really quite straight. So a rotational force is quite appropriate there.
We use lignocaine for our nerve blocks. That's the agent we use for this cat and for the dog previously. If this was the sole, so we're working in this arcade. Both Beck and I tend to use caudal maxillary blocks. You could use an infraorbital block on this cat for this tooth. That should be actually quite an effective block for this area. But both of us generally solely use
I pretty much just use caudal maxillary. I find it easy to place. You've got to be super careful in how the depth of penetration of your needle. I will literally just put it in so the bevel is through the tissue, no deeper. And always draw back beforehand. But there is a risk of orbital damage. I think all blocks in cats, unfortunately, with maxillary carry some degree of risk, infraorbital included. If you insert into the infraorbital canal, the orbit is literally just behind that. So I guess the take-home message is you'll hear lots of pros and cons about each one. Do what you're comfortable with and just be really careful.
Yeah, that's the big asterisk to it. Certainly the caudal maxillary block and not the infraorbital block, then neither of them are immune to causing damage to the orbit. So Jason's got a comment here really about use of Vettome. The Vettome, if you've not come across it, is a mechanical peritome instrument that uses fine, sharp blades to incise the periodontal ligament. And Jason's used it previously to really get in that palatine aspect. And absolutely, a nice thin object like the blade of a periotome, or the Vettome specifically, will work down that area and break it down. And that's what we're aiming to do. Beck and I have used the Vettome. We had access to one for quite a few months, just prior to general release, just to get hands-on and find out a bit more about it. We both liked the machine. It's quite decent.
I found it too heavy for me. Like, I didn't feel I had the control and dexterity. The handpiece was just a bit too chunky. And getting it into all areas of the mouth for me was difficult. But
we both felt that really it has a place in your armamentarium. Probably, I think it's probably stars in mandibular canine extraction in dogs. we ended up not going with one. Maybe we're a bit pig-headed, that we stick with our old trusty surgical techniques, which we're talking about tonight. I think there's a place for it, but it actually does, for us, it actually doesn't appear in our range of instruments.
No, it didn't really save any time for us.
Again, look, we're lucky. We do thousands of teeth a year, so we're pretty used to doing this. So yeah, it didn't offer much for us. But I personally have nothing particularly against it. I think you need to be careful with it. It's again, like just talking about a nerve block, for instance. It's not without its potential problems.
Yeah, you need to make sure that the blade you've got on it is appropriately sized for the tooth and the patient as well. And I actually used one on a greyhound and still got an oronasal fistula with one as well. So
yeah,
you know, it's not, I guess, I think there was possibly a lot of focus on how atraumatic it was. And yeah, it can absolutely be. But I still experienced a few negative effects from it. And I still think that you, at least, you know, if you're using it, fantastic, it works well in your hands. But for canines especially, you still want to close these as well. So there was a little bit of thought going around and some people sort of advocating that you didn't have to then do surgery to close these extraction sites, and generally I'd argue that. So you still got to put the preparation into creating your flap and closure and the likes of that as well.
Yeah, for sure.
So that was, I've already run through, if you're watching, basically that's just the release in the cap. So just really, and as Aaron said, you're almost just scratching the tissue basically to release that periosteum there. And again, if you're worried or if it's a really thin flap, just sort of do that without sort of using your forceps or use your fingers. Just don't cut yourself.
And again, if you've prepped that all up with no tension, away you go, suture it closed. I think at this juncture, I guess we sort of touched on a little bit. I'll raise the issue of breakdown of flaps. We didn't really plan to talk about this that much. I'm bringing up because where's it going to happen? Cats. Cats and their rough tongue can remove sutures within minutes. I think sometimes certainly our suture placement and our site preparation plays a role in breakdown. It has to, unfortunately. I wish we could always blame the cat. But I think cats themselves do play a pretty large role in the breakdown. It can look really awful. You can have these cats represent a few days later and you can see a big open alveolus, you see open bone, you've got food packed inside the alveolus, which often is mistaken for infection. It will be surface infection in chunks of meat or whatever they've been eating. And it can get a bit whiffy, but it's generally not a deep infection that requires antibiotic use. If you can keep them clean, and that may require the cat coming every few days for you to actually clean and keep the inflammation and pain controlled, they will heal. I've yet to go. Have you ever been back into one, Beck?
We've had one that was referred in, and I think there was just a problem with that cat's healing, to be honest. It got better, but it never quite closed over completely. And I think that was more of a cat problem than an actual problem with the surgery per se.
Well, they generally do. They can be situations where you have to hold the hand of that client through the next month as it does heal. Because it's difficult for them. That's not the planned outcome, of course. A wound that is not healing is unpleasant. But I think the cats do okay with it as long as you're covering them off with.
And the big thing, I think, is don't play with it too much. Flushing it every day and sort of cleaning it out too much can actually disrupt the healing more than it contributes to aiding in healing. Don't put chemicals in there. If you're going to use anything, use saline. Anything over a 0.05% concentration of chlorhexidine will impact fibroblasts negatively. So that can actually really slow your healing down. So if we do it, we probably would see them weekly. And, you know, if it's got a lot of stuff in it, just give it a little flush. Don't really disrupt it too much more than that. Diet adjustment just to sort of reduce foods that pack in there and stick in there, and they'll generally get better so much more rapidly than if you're interfering with them a lot.
Yeah, we tend to physically remove any gunk out of it with forceps rather than wiping. Wiping is the worst. Like you'll wipe away just this early granulation tissue. It comes away quite easily.
Yeah.
They take time. I think the longest I've ever had was one in general practice that, from many years ago for me. It took 2 months. But in the end, it all healed up, was great. But yeah, just walked everyone through it, managed expectations, and we got there.
Yeah, for sure.
Okay,
We've
tips and
covered all
tricks.
these points really, but
Yeah, I think so.
preparation of a flat with a good blood supply, taking only as much bone as you need, but also if you're not getting anywhere, take some more. That's not really a problem. Make sure that those deep sort of cuts are deep and then narrow as well. You need to be precise with those incisions. Release of your periosteum will really, really reduce the amount of breakdown that you have. And also just, I guess we put, as you've probably seen, more preparation and more time into preparation of our site for the extraction. The extraction is often the shortest part of the procedure. And then also in preparing the site to close it effectively. So we really clean up that tissue. So if we do have breakdown or the likes of that, it's a healthy site to start with. We don't have bony fragments that are going to come loose. We don't have jagged areas that the tissue's got to migrate over. It's a healthy, nice, clean, sort of smooth surface. And I think, I guess when we do encounter breakdown, and we definitely do, the healing does tend to be fairly rapid and we don't have a lot of the complications. And in most cases, we won't even put them on antibiotics if we do have it. Sometimes to hold the owner's hand that a little bit more, we might.
Yeah, antibiotics are, just often placation of owners.
Yeah.
That's an expectation of them. Again, and it is called that. I see it profession-wide that often, it's got infected. And they rarely are infected, but everyone thinks it is. And in fact, and unfortunately, we get phone calls from clients going, I've had my cat's tooth taken out and there's a big hole there now, and they're not putting on antibiotics to fix it. If they had to put it on antibiotics, it would have fixed it. And that's just
it wouldn't have happened.
No, it's not the case, but we all do it. And again, it's against, as much as it goes against antibiotic management or resistance management issues. I will do it. I will do it just to shut them up, make them feel like we're doing something, even though, again, as we just said, it really is time is required for this to heal. If I think they're actively doing something with antibiotics, that makes them feel comfortable in that meantime.
Yeah.
There's not too many complications, I guess. We were going to talk about surgical breakdown. Oronasal fistula, we might even come back in the future and even cover that as a specific topic. It might actually be worthwhile. But yeah, oronasal fistula can come about through, it could be iatrogenic, an oronasal fistula. If you've rotated a canine and punched through, you can do it with instrumentation as well. If that's the case, that's actually quite a successful procedure to fix, because you just need to close it like you're going to anyway. That will be successful. You don't have this indwelling nasty infection that's caused oronasal fistula, probably. It can come about through breakdown. So you've had an oronasal fistula and you've had the second point, you've had a surgical wound breakdown and it's just reopened the fistula. Again, that's why I think, we probably should do that as another topic at some point. It's complex, but it is basic. Basically, you just do a bigger version of what we just discussed tonight. Actually, leave it at that, really. That's what you do to deal with it. But they can be
all the same principles, really.
Yeah,
sometimes on a slightly bigger scale.
Yeah, they're frustrating and they can be hard, and certainly they may be something that you go in 2 or 3 times to try and fix. Lip entrapment, I guess we see that mostly in cats. Actually, I won't answer that. I see that we've got a question. That's a classic one, Cara. That's really difficult, and Beck nailed it just before, as she said, where we need to plan for these, and it's site preparation, which is going to help us achieve success. We remove a lot of that nasty tissue on the edge. Again, as much as you go, oh shit, I don't want to lose more tissue, but our flap creation then starts to move up way more into mucosa and even going up into the lip mucosa. And look, it changes the shape of things a little bit, but you need to get that tissue that's gone.
And you'll be surprised how much if you use your, like, get some nice little scissors or something like that and use the grange scissors, you'll be surprised how much extra length of that flap you'll get just by sort of getting up and releasing that little bit of muscle in I guess that base of your flap. I often, there's ones you go and you're like, oh my gosh, how am I going to close this? You make your vertical releasing incisions and you might extend them higher than what you normally would. You sort of release that tissue more than you normally would, and 9 times out of 10 I end up having to trim tissue off because I've got too much, and that means it's a good thing because I'm trimming off all unhealthy tissue, and I'm also the other thing is making the flap a really nice shape. When you've got that V-shaped sort of area of recession and then you pull it down, you'll have these little sort of, thin tendrils of flap on the edges. I'll pretty much trim those back almost to the edge where the actual recession extends to. I'll trim it off almost to that level and then pull the whole flap down, and it sits much, much better. It honestly will generally surprise you how much tissue you can actually harvest and migrate down. As I said, 9 times out of 10, we're actually trimming excess off to actually get it to sit nicely.
Yeah, absolutely.
But it's really careful debridement of the edges as well. That's super, super important, and getting rid of all the granulation tissue and having fresh edges on the buccal and the palatal side of your flap.
But unfortunately, it is common. And I'm not sure if actually everyone else can read the question. I assume you can, but I'll quickly just read out what Cara asked. And she was asking about those the dog canine extractions you see where they've had severe periodontal disease and they've lost a lot of that gingiva. It's gone a lot of recession around it. So your flap, if you create it as per usual, will not be large enough to actually come and close that alveolus completely at the end. Okay, so lip entrapment, we see that mostly in kitty cats. I've not really ever had many issues with dogs. Certainly had dogs with the mandibular canine sitting outside the lip post maxillary canine removal, but it's really only in cats where you see trauma occurring from that mandibular canine, and usually it shows up as these cats that come in and they have this marginal lip ulcer. And they're not agony, they're not going to die, but it's uncomfortable. So unfortunately, the way that our approach to this is we talk to all our cat clients that we have a canine extraction or a planned extraction. And we mention it's a possibility. It doesn't happen frequently enough that we do an immediate treatment to the mandibular canine. But if it does occur, I guess there's a couple of ways to approach it. If it's occurring initially, I always give them about a month to see what really happens. I have had many cats that develop it quickly, but then as things settle down, things heal, things just change that maybe millimeter to 2, and it becomes okay again. I've also had them go the other way. They were initially fine, but then a month later, they've actually started showing signs. The way to resolve it is we need to unfortunately deal with the tip of the mandibular canine, and it needs to not be there. So there's only 2 ways for it to not be there. One is complete removal of mandibular canine. The other is if you want to send them our way, I guess we do a mandibular height reduction. So we remove the large, sharp, stabby bit of the tooth, and then we perform a vital pulp potting on that. That's more involved, of course, but that's for people that really say, I really need to keep that mandibular tooth. And the last complication that we do see from time to time is collateral damage. Nearby teeth can be damaged and even extracted inadvertently through this process. The premolar 1, unfortunately, many premolar 1s have suffered at my hands through the years. And that it can be, again, it's with our rotational force on that distal part of the canine, that force can push, and they usually are somewhat diseased anyway, but it can push on the root tip of premolar 1. They should pop it out. The other thing that can happen as well, unfortunately, you can actually cut the tip of the premolar 1 as well in that distal incision. Particularly in brachycephalics, you need to be aware of that. Of course, everything's quite crowded there. What do you do? Look, honestly, for premolar 1, if you're aware that you've done that, I would extract that tooth. I don't think that tooth's not going to live if you've cut the apex off it. So just remove it. It's unfortunate. It's certainly not necessarily something you're aiming to do, but loss of a premolar 1 in the scheme of things is very minor for a dog. Incisor 3, yeah, you have to be pretty cramped, but that potentially can get caught up in your measly incision. But that's about it. I guess the other thing we talked about when we were putting this together was, well, how about fracture of canine teeth? It certainly can happen. Absolutely. I've not really come across it too much in maxillary teeth. It does happen. I've had to retrieve roots that have been accidentally left behind, but it's not that common. If and when we ever do a mandibular canine extraction webinar, which will shock the pants off everyone because no one likes those guys, that's a tooth that certainly fractures more frequently accidentally.
It does.
Yeah. And that's about it. I think we've achieved what we wanted to achieve and covered everything we wanted to. Again, I've realised that we both like to talk about teeth a lot. So thank you for hanging in there for 90 minutes as we gabble on about extracting maxillary teeth in the dog and cat. But hopefully you got something out of that. I know it is a topic that as veterinary dentists, it's presented quite fairly frequently in all the different conferences around the place. This is our take on it. This is what works for us. We think this is following these techniques.
It's a pretty consistent result.
Yeah, it's predictable, and hopefully it's just takes a bit of stress out of your life.
Yeah. And if anyone's got any more questions, throw them up. Happy to answer them.
Yeah.
I think there's also a little survey Bianca's done for the end of this as well. Just we've had some feedback and also for future topics as well. I think plan would probably be to do some more on specific teeth for extraction, but also we're working on some radiology ones as well, because that seems to be a pretty popular topic that people want to learn more about.
Yep, excellent. Well, thanks, Beck, and thanks everyone for your attendance tonight. Hopefully we've given you something you can take away. But yeah, we'll hang around for a little bit longer. If anyone's got any questions, we'll stop the recording now. These recordings will go up over the next couple of weeks on our YouTube channel if you want to have a look at it or tell your friends. Yeah, if you want to revise that again, yeah, it'll be accessible for indefinitely. I don't see why we would take them down.